Aloha, everyone. It's great to see you. And thanks for joining us for this very special webinar today. You know, this doggone COVID environment we've been living through for the past couple of years now has been just really challenging. And what better time than now to have an update, right? An update on COVID, especially given all of the new variants and all of the new information that's been coming forward. And so we're really pleased today to have Dr. Melinda Ashton join us, the Vice President and Chief Quality Control Officer at Hawaii Pacific Health. And I have also been asked to encourage you. I hope you brought your questions with you, because a big part of this session will be dealing with answering and responding to your questions. So let's join the session, and I turn it back over to you, Dr. James.
Hello, can you guys hear me okay? Well, hey, just my pleasure to
Yep, I can.
yeah, it's my pleasure to introduce Dr. Ashton. Her background is actually quite easy to follow because she did her medical school, her residency, and her pediatric infectious disease fellowship at the Johnny Burns School of Medicine here. So she definitely knows Hawaii very well. And what a better person to represent the people of Hawaii, and as well as you know, her specialty of infectious disease, to actually, you know, help us with this pandemic. So when it first hit us back in February and March of 2020, a lot of us, including myself, we just didn't know, right? And Dr. Ashton was one of the first persons that I kind of listened to during one of these HPH sessions, and she kind of really did her research. It's obviously, she's well versed in virology from her training, but also how it affects us here locally in Hawaii. And I'm just really honored and privileged here in Hawaii to be working under, I guess not technically under her, but with her at HPH. But it's just you know, it's just awesome to have a leader in our organization also willing to come out to our community, come out to our Rotary Club, and actually you know, give us some knowledge. And just like my my message kind of quoted with was saying that knowledge is power from Sir Francis Bacon, you know, from another pork product meat, Dr. Ham here, I just want to introduce Dr. Melinda Ashton to our wonderful stage here in Rotary via Zoom. Thank you, Dr. Ashton.
Oh, thank you so much for that really nice introduction. So I was really grateful to receive a series of questions from Dr. Ham, some of the questions that you all are asking. So I've tried to put a brief presentation together to answer some of those questions. But as was already mentioned, I'm really interested in a discussion more than a presentation. But for those of folks that work with me, they know that I never go anywhere without slides. So I'll show a few and we'll see how we do. Or at least I'll try to show a few. Let's see if I can find it. There we go. Are you able to see the slides? Okay, great. That's always a good start. All right, so one of the first questions that I was given was, how are we doing on herd immunity? And so I thought I would start with a definition of herd immunity, which really is around, you know, a pre-existing immunity of a high proportion of individuals, so that really the goal there is to stop the spread of an infection because everybody's immune. And we were all hearing a lot about herd immunity early on in the pandemic. Unfortunately, this concept is no longer relevant. And so strike it from your memory banks, because with COVID now, it spreads so much more easily, and we know that immunity fades over time, that herd immunity is no longer a goal, probably not achievable, and not really worth thinking about too much anymore. So that's disappointing, I think, frustrating maybe, but certainly is kind of where we are. So I thought I would show you one of the charts that we look at regularly, and sort of indicating just how active COVID has been and at what period of time. We began obviously paying attention to COVID back in March of 2020, a long time ago now. And we had, you know, a very few cases early after that, and then a wave of additional cases in the summer of 2020, winter of 21, and then, you know, the big Delta surge last August and September. But the amount of cases of Omicron just puts everything else into, you know, perspective. The number of cases of Omicron is just hugely different than the previous waves. And so I put your on the bottom here, 223,000 cases that have been reported as positive. So we know that there's a huge number of cases that were either not tested, were tested with a home test, or not reported. And so it's way more than 223,000 in Hawaii, and 1,194 deaths since the beginning of the pandemic. So hugely impactful, of course, to all of us, not only with this sort of stuff, which I live every day, but just our day-to-day activities and our world, right? The whole worry about COVID was around overwhelming the healthcare system. And all of the restrictions that were put into place early and subsequently have all been about trying to make sure that the healthcare system doesn't crash and burn, so that we can't take care of folks that need care, whether for COVID or otherwise. And so this chart, I think, is helpful in putting into perspective how we've done with the Omicron surge, which I just showed you is hugely bigger than the Delta surge, but we have not actually reached the same peak of number of people in hospital. Not surprising, but actually a relief, because there were some predictions early on when Omicron first started to increase in Hawaii back in December. There were some predictions that we would be seeing many, many more people in hospital and that the hospitals would be in big trouble. So we all know, I think, Omicron spreads much more efficiently. So that's why the huge number of cases. It does cause illness more quickly, and it is contagious more quickly than the original form or the Delta form of COVID. For most people, it's a much milder illness. And one of the really important things is, unlike the earlier versions of COVID, it doesn't go into the lungs in the same way. So we don't have people on ventilators or with huge need for oxygen, which has been really, really helpful. Fewer people have a loss of taste and smell, also going along with the way that Omicron works. More people have gastrointestinal upset, so vomiting and diarrhea, abdominal pain, back pain. And really commonly, if you have symptoms at all, and many people don't have any, nasal congestion, sore throat, and sinus pressure. So it feels kind of like a bad cold for many folks. So one of the questions that came from you all was, if it's just a cold, why are people dying? That doesn't make sense, does it? We're talking about milder. We're talking about it doesn't get into the lungs in the same way, but yet we are still reporting deaths, most days. We do know that for those folks who are fully vaccinated, including a booster dose, they have a 97% protection against severe illness and death. And I'll show you that study information a little bit later. But some people haven't chosen to be vaccinated. And those folks that are not fully vaccinated, who have individual factors that are leading to their health being precarious anyway, they are ending up in our hospitals. So we have people, we call them medically fragile in pediatrics, actually, where there's significant illness that doesn't take much of an insult to tip you over the edge and get into trouble. And that's what we're seeing in both adults and in some kids. We're not seeing many kids in Hawaii who are getting in the hospital, but those who do come in generally are because they have other really significant illness, and this viral insult is enough to unbalance their precarious balance. It is absolutely still true too that the older you are, the more at risk you are. And so it's that individual sort of circumstance that really matters with how you do with Omicron, as well as any of the other COVID versions as well. Another question that came up was, how are we doing for those groups in Hawaii that have in the early phases of the pandemic were much more significantly impacted? So we know that the Native Hawaiian, Pacific Islander, particularly Micronesian populations were very heavily impacted early on, with severe disease and death being much out of proportion to their share of the population. I pulled this chart from the Department of Health data set, looking at what's happening now during this Omicron period. So these are cases that occurred on or after December 5th of 2021. And you can see that we're not seeing that disproportionate infection rate among Native Hawaiians, Pacific Islanders, and others. This is an interesting fact. It's not clear to me exactly why. potentially because they had such heavy rates of infection earlier that they may have some immunity and may not be symptomatic in a way that leads them to get tested. I'm sure you probably are aware there's been plenty of news about this new version of Omicron. So, variants continue. So it's in the media, they're calling it stealth Omicron. And the reason it's being called stealth is one of the ways we test for COVID infection is with something called a PCR test. With the Delta versions and versions before that, there was a particular pattern on a PCR that was positive. And then when Omicron hit, it was noticed first in South Africa, and they found that there was a particular different pattern on the PCR positive test. Now with this stealth Omicron, we're back to the original pattern. So we can't actually tell it's Omicron just by looking at that pattern. There needs to be further testing to know that it's still an Omicron variant. So this is a subvariant. It's been quite active in several countries around the world, including Denmark and now the Philippines and a number of others. We do have it in Hawaii. It appears to be even more transmissible than Omicron, which already was one of the most infectious viruses we know. So far, and there's some controversy about this, but so far it doesn't appear to be more severe than Omicron. It doesn't appear to get into the lungs the way that Delta and previous variants did. So that's very good news. The Department of Health does test for these variants, but their data tends to be quite delayed. And so it will be several weeks before we see if this subvariant or stealth Omicron really picks up the pace. Another question that came from you all was around long COVID and whether those with an Omicron infection can have a risk of long COVID or really prolonged disease. So I thought it would be worth talking about the World Health Organization definition of long COVID, which they actually don't call that. They call it post-COVID-19 condition. And this is a condition that occurs in people who have probable or confirmed coronavirus infection. So SARS-CoV-2 is just a scientific name. It has to be, in order to diagnose it, you need about 3 months from the onset of that infection. And symptoms need to last for at least 2 months and can't be explained by something else. So common symptoms are fatigue, shortness of breath. A lot of people describe this brain fog kind of feeling of not being able to think as clearly as they would have expected themselves to prior to the infection. And then other symptoms are included as well. Now, the reason we don't know yet about long COVID and Omicron is this issue of it needs to be 3 months after that diagnosis. Omicron's only been around, even in South Africa, it wasn't described until right before Thanksgiving. And so we're barely at 3 months for South Africa. We're not at 3 months really yet for most of the US. So we really just don't know if long COVID is going to be a feature of Omicron infections. There's not much reason to think that it won't. You don't have to have had a severe infection of the other variants of coronavirus in order to get long COVID. In fact, people who didn't even know they had COVID can have long COVID. So you could be asymptomatic with the original infection and then get into these complaints of being very tired and having brain fog and such. We do expect that because Omicron doesn't cause the lung infection in the same way, that the shortness of breath piece that many people suffer from will not be likely. Another question or series of questions that were asked were around treatment, current treatment. It's quite possible that you've all heard about monoclonal antibody treatment. President Trump, when he was infected, received monoclonal antibodies, as have a number of other people. It was found early on with the Omicron sort of wave that the monoclonal antibodies that we had been using were not effective. And so we have now this one type called Cetrophomab that is effective. And at Hawaii Pacific Health, we've been providing this treatment to patients. So the patients are selected because they've got a positive COVID test and they're at risk for severe COVID disease. So they have a comorbid condition or they're older, or we have a whole list of criteria as to how people qualify for this treatment. It needs to be started pretty quickly. And so we actually monitor the positive results and look for people that would qualify for this treatment and then try to get them to come in. It's an IV infusion, so we have to start an IV and we have to, have nursing care and so forth to make sure that folks are safe. And then we have to watch to make sure they don't have an allergic reaction. But it's well tolerated and it seems to be helpful. So one of the issues with Cetrophomab is it's in relatively short supply. So the state manages the supply that is provided by the federal government, and they get the doses get distributed out to the various folks that are providing this care. Additionally, new to the armamentarium are a couple of oral medications, and this is really good news. To be able to have some pills that we can give to folks who would be at risk for severe disease is a great step forward, and pretty recent, just in the last month or two, I would say. One of the issues with, again, in very short supply, so the supply is being managed by the state, comes from the feds on an allotment, and then it is distributed out to the various places where we are able to dispense it. The Paxlovid is actually the one that is being used more often, but both of these medications have a lot of interactions with other medications that people take. And the people that we are going to treat are going to be folks who have comorbid conditions and are commonly on medication. And so it's not uncommon for us to find that we can't use these medications, even if we wanted to, because of the potential side effects or interactions with other drugs. And so we are more commonly falling back on the Cetrophomab, the IV infusion of monoclonal antibody. Since early on in the pandemic, we've been using a medication called remdesivir, and we continue to do that. And then steroids have been used a lot as well. Those are mostly for patients in the hospital, although recently remdesivir has been recommended for use in the outpatient setting. Unfortunately, it requires infusions 3 days in a row, and that's pretty difficult to organize. So that's a bit of a problem. Excuse me. And then lastly, there's this medication called Evusheld. This is a medication used for people who have a risk of severe disease with COVID before they get COVID. So it's actually a preventive medicine that lasts for about 90 days. And so they can receive, it's a monoclonal antibody as well. They can receive this medication and it will help to reduce their risk of infection with COVID. The one thing that some folks ask is, well, I don't want to get a vaccine, so I can just get that medication, right? And that'll reduce my risk. And it's actually not allowed to be given to folks who have not been vaccinated by choice. So it's not a solution for that set of folks. So those are the medication things that we have right now. And then there were several questions around some of the COVID-19 vaccine kind of issues. So let me show you the first one. Question around, hey, I'm vaccinated. Do I really need a booster? Is the booster going to make any difference? And so, again, I told you I would show you this study. So this is a study that was published, that MMWR Weekly is the CDC way of getting out scientific study information. And so what this was a large study, actually. And back from the time when Delta was active, not Omicron. And it showed that if you had 2 doses of mRNA vaccine and you have no immune compromise, you have an 82% reduction in the risk of severe illness and hospitalization. If you have the booster as well, it goes up to 97%. And then for those folks who do have immune compromise, they have less protection, but still much better protection with a booster. Next question that came in was around myocarditis. I know that many people with, particularly with teenage sons, very worried about myocarditis. Myocarditis is an inflammation of the heart muscle. That's what it means. And what we know is viruses cause that in this population anyway, commonly in adolescent boys or young adult men. And so COVID, the virus, the infection, can cause myocarditis and does. It turns out that the vaccine, the mRNA vaccine, so Pfizer and Moderna, can cause myocarditis as well. Most of the media attention has been to the vaccine-associated myocarditis. It turns out that the viral infection causes myocarditis more commonly than the vaccine does. And so if you're worried about myocarditis, it's actually a really good idea to get vaccinated to prevent it from the viral infection. But I think that that piece isn't commonly sort of discussed. A couple of other vaccine questions. When can younger kids get vaccinated? If we had talked last week, we would have said not quite sure. This week, we know that Pfizer has applied to the Food and Drug Administration for an emergency use authorization for 6 months to 4-year-olds. That will be several weeks while it wends its way through the FDA and then the CDC. But we expect that by the end of this month or early in March, we should be beginning to vaccinate 6-month-olds to 4-year-olds. The interesting thing there is that the EUA application has been for 2 doses, and we know that 2 doses by themselves are not sufficient. So we expect that very quickly they will also provide information about the 3rd dose that they've been giving to these kids. And then likely the EUA will be modified to include a 3rd dose. So it's not a booster dose for this age, it's 3 doses in the primary series in order to get the protection that they need. And then the question that we get asked a lot is, when do I get my next booster? Or will I need a 4th dose? Or are we gonna have to take this annually? Nobody's really sure at this point, but there would be no reason to think that the booster immunity that we enjoy now that makes such a difference will sustain. We're very likely going to have to get another dose, perhaps a dose that's more specific to the variant that's happening at the time. Both Pfizer and Moderna are working on Omicron specific vaccine. So we don't really know, except that it's likely that it will end up something like the flu shot where you have to get it on a relatively regular basis. And then just to sum up before we have more of a discussion, some questions around, okay, so what, how do I make sense out of this now? What do I do? From our perspective, making sure your vaccinations are up to date, making sure you've had that booster if it's been at least 5 months since your 2nd dose of mRNA, if that's what you had, or 2 months after J&J. It still makes sense to wear a mask in public indoor settings. It really isn't necessary to wear masks outside unless you're in large, concentrated crowds. Lots of fuss about what kind of mask from the CDC and others recently. I don't know how much that truly matters. Wearing a mask that fits you well and that you don't wear below your nose or under your chin is probably most important. And then whether you're wearing an N95 or a KF94, one of those, if you can get them and they're comfortable for you and they fit well, then that's fine. And then questions around travel. My advice around travel has always been pay more attention to what you're doing at the airport than worrying about what's happening on the plane. The airplane does not seem to be a high-risk environment. They have actually done a pretty good job with the air filtration and all the rest of that. And once you're sitting in your seat, unless you're very unlucky, and sitting next to or right in front of someone who's, emitting a lot of coronavirus, you're probably okay on the plane. But it's the checking in and the lining up and the TSA and the, all of that and everybody getting off the plane, standing up together. Those are the times when you need to pay more attention to making sure that you've got a mask on and that you're being as careful as you can. And then lastly, a question around healthcare workers with burnout. This is a real issue, and I don't think it's just healthcare, but certainly we know that a lot of people have found that this pandemic has led them to reevaluate their work life, personal life, where they live, all of those sorts of things. At Hawaii Pacific Health, we're very concerned about the effect of the pandemic on our employees. One of the things that we've noticed is that when we're very busy, which we are right now, with patients in the hospital and busy clinics and all the rest of that, people in healthcare just tend to keep going and rise to the occasion and provide the care that's needed. What we worry about a bit more is when things slow down again and people have a minute to think. That's when we feel like we really need to be in there supporting them. And we do have, we have already had a number of employee sort of well-being activities, and we're continuing to enhance that and have folks that are out on the hospital floors just available to talk if you have a problem about that you would like to talk about. So we need to do a lot, probably a lot more than we are, but that's what we're doing so far, just recognizing that it is an issue and trying to provide those employee assistance programs and others that make a difference. So I think this is going to be a problem that's with us for a while, and I suspect that all of you in your various roles are seeing it as well. So with that, I will stop my slides and really, happy to answer any questions, engage in any discussion that you would like to.
All right. Well, I guess first of all, I just want to just thank Dr. Ashton for helping us out here. Let me turn my screen on. Sorry. Just want to thank Dr. Ashton for jumping on this call with us. So everyone just give her a round of applause. Just say thanks. What we do in person, right? Just say thank you. And yeah, it's also it's a nice day like always in Hawaii, but you're definitely taking your time out to do this for us. I really appreciate it. But I know that a lot of you guys have questions. I've seen some in the chat window. So maybe we could just start off with some of those questions. I think actually, yeah, one of our Lolos, you want to just ask your question on just yourself, and I want you to introduce yourself and yeah, go ahead.
Yes. First of all, thank you, Dr. Ashton. My name is Carlos Gerges. I go by Lolos. I used to work with Dr. Ham. Now I work at Queens Medical Center. A lot of my questions were just passive curiosity. I mean, I don't have to dive into them. But the last question I was curious about with you saying that there's a chance that we might have a vaccine for Omicron variant. But with it being so mild, I'm wondering if there's any benefit to producing a vaccine for Omicron variant, especially if it mutates again.
I think that's a good question, actually, but the vaccine manufacturers felt that it was important to do that, and it's mild for many, but it's not mild for all, right? So the deaths are still continuing to occur. Every day in the United States, many people are dying, and many of them are dying with Omicron. So it's not completely benign. It is milder, certainly, than Delta, thank goodness. But the vaccine manufacturers felt, I think, that it was important to create those vaccines for the variants. And I think the interesting thing is one of the things they're doing with that is sort of a proof of concept that they can make a variant vaccine quite quickly. And so if the next variant is back to a different level of severity and so forth, they're proving to themselves and to the rest of us that they can do it.
Okay. Any other questions? Just raise your hand, or Jay. Actually, Jay. Yeah, I see your question written. If you want to just read it out for us, so that we could, some of us reading impaired people.
Thank you so much, James. I appreciate the invite to this, and Dr. Ashton, thank you for your presentation. My question was related to the requirement at venues, restaurants, and bars for vaccination card to enter. Since it is now known that the vaccine or vaccination doesn't prevent transmission, especially with the Omicron variant, should we do 100% testing of everybody entering venues to ensure that everybody entering has got a negative COVID test? And if that's not feasible, then shouldn't we just scrap that entire requirement in order to enter into restaurants and bars and let people decide what risk they're willing to take going into indoor venues?
Yeah, you ask a really good question. I am certainly not involved in policy. And so I think that some of that reflects more about the state of policy and policy decisions that have been made. Personally, I think we are about in a period of time where it's really informed individual responsibility. And the vaccinations have been available for a very long time now. People can choose to do that or not. You are absolutely correct that being vaccinated and boosted does not protect from infection and being able to spread the infection. So that removes a level of protection that I think was hoped for. There are some announcements of some versions of vaccine that are going to be a nasal spray that may in fact help to reduce that nasal replication, that would also help to reduce the infectiousness. So maybe those will be helpful. But the hope that, if you were vaccinated, you would then be safe in every possible way is just not where we are. And so I think the requirements for public venues with vaccination has been considered kind of a carrot to get people to get vaccinated, which, from the public health perspective, clearly is something we would all like to have folks do.
Okay, next question. Kurt, I see you in a text. You want to just go ahead and ask a question? Thank you.
Sure. Thank you, Dr. Ashton, too, for your time. So my question was, you kind of mentioned that individual circumstances kind of matter in regards to the person's health. My children are, from 13 to 18 years old, and should they all get boosted, or should I contact their pediatrician? And have there been any studies on any type of, this has been around only for so short a period of time, but what could be the possible long-term effects of getting?
Okay. Talking about the vaccine.
They already been vaccinated, but I'm more talking about boosting, and then probably
Sure.
the next round of boosting after that. So.
Yeah. No one can truly answer the question about long-term side effects because the vaccines have not been around for long-term. However, there is really no scientific reason to expect that there will be long-term effects from the vaccine based on what we know about how the body reacts to the vaccine and how vaccines in general work and how immune system works. There's really no reason to think that there is going to be some hidden horrible something that comes out a year, 3 years, 10 years from now. There just is nothing scientifically that we are anticipating will be an issue. But yes, I hear that all the time. These are quote unquote experimental, brand new. We don't know enough, but we have given hundreds and hundreds of millions of doses, and so we actually know a whole lot more about these vaccines than about many that we give. And honestly, nobody can answer the long-term question that you're asking just because we don't have long-term yet.
And kind of to go along with that, I guess, my son has been vaccinated. He's 18 years old, and you talked about myocarditis. Is there more of a risk? I know that it seemed like it was happening more on that second dose, but what about on this third dose or the fourth dose?
Right.
Should I be worried about that?
My understanding is that we're not seeing it reported as much after boosters. But again, teenagers have not been getting vaccinated for quite as long as older adults. And so potentially we might see it, but it just hasn't come up yet as a big issue with the boosters. It really was around the second dose that we seem to see most of the issue. And again, although we all know about it and it was made a big deal, it's a tiny, tiny number of cases, 1,600 cases with 300 million doses. So when you put that in perspective, it's really, really tiny.
If we took that sliver, not going from 18 to 30 or 16 to 30, and he said, 16 to 18, would that percentage change? Would it make it
It
go
would be
up? Or?
even tinier, right? It would be just
Okay.
a really minuscule number.
Okay, because then the amount of doses that they would have had would also be a lot smaller too.
Right, but
Yeah.
still, in proportion, it's still very, very, very small risk. Now, that doesn't mean that if it happened to you, it wasn't a scary deal, right? I mean, we've had kids, athletes who've had myocarditis, who've, ended up in the hospital because they came in with chest pain, and everybody gets very, very nervous about all of that. And then 2 days later, they're better and home and just need to be followed up to make sure they continue to recover. So the good news is that's the vaccine kind of myocarditis. The myocarditis that occurs with the infection is far more worrisome, because the longer lasting effects are more of a concern. So if I had a teenage son of that age, I'd be hoping for vaccine related myocarditis, not illness related myocarditis.
Thank you.
Sure.
All right, thank you for that great answer. It looks like I skipped Shelley. Shelley, do you want to go ahead and ask a question, Dr. Ashton?
Yeah, hi, it's Sally. I had two questions. First, how effective are home test kits? And then secondly, how long after having close contact with a positive person should we wait before taking a test?
Yeah, good questions. Thank you. The home test kits vary in terms of their reliability. All of them are not as good as the PCR type tests that we rely on, but they're good enough for the most part. And that's why the government has decided to try really hard to get many people to have, home tests available to them. The question of how long you should wait to take them, it actually turns out that for many of the home tests, they take a little longer to become positive than even the PCR does. We know that with Omicron, people can start to shed virus within about 36 to 48 hours after being exposed, but the test may not pick it up right away. So if you can wait, it's better to wait another day or so. So if you wait 3 days or so, that begins to get you where the test is more likely to be positive if it should be positive. The other thing with home tests is it's better to do more than one. So you do one on 3 days, potentially do another one in a couple more days. And if they're both negative, then you're in pretty good shape to believe that you might be negative.
Thank you. That was super helpful.
Sure.
Okay, Dr. Al Whalen had a great comment. The concept of personal responsibility seems at odds with the public health emergency. I think that's kind of from the start, right?
Yeah.
And that's what may have gotten us a lot in trouble. Of course, nobody wants to wear the mask. Nobody wants these mandates, but kind of have to think out for others. And I think that's the beauty of Rotary and kind of what we do in Rotary. We actually care. We are people of action. We actually have these mottos like service above self. And I think that's what separates us. So in a way, it's kind of preaching to the choir, but at the same time, it kind of revalidates why we joined Rotary, why we are here, why we are in this community. And just want to see if there's any other questions before I jump in with some of my own that I've kind of collected.
James, if I could just comment on that one as well. I think very clearly at the onset of the pandemic, it was critically important that we had really good public health oversight and mandates and responses, and because we didn't know what we were dealing with. But we're 2 years into it now, beyond, and the virus has changed. The immunity level in the community has changed. All kinds of things have changed. And so I think that we have to be able to recognize when some of those mandates are probably no longer, certainly probably not necessary as much, but also maybe not effective anymore. And so I mean, there's a constant tension between, should we lock everything down again, and if we tried, would it work? And is it necessary anymore, right? And so I think the one thing that we hear a lot of frustration about is that the guidance keeps changing, the CDC keeps giving us new things to do, or, all the rest of that. And that's because we're not in a static environment. The virus has changed, the pandemic circumstances have changed, the immunity level in the community has changed. And so I think that it's not surprising that we would see a changing response.
And that's exactly what our next question is with Naomi. Perfect timing, Naomi. You want to go ahead and ask?
Sure. So Dr. Melinda, when is someone contagious and how long are they contagious?
It probably varies among folks. So some people are certainly contagious for longer. If you have problems with your immune system, it takes longer to shut the virus down. So prior to Omicron, we know that it took up to 20 days and sometimes months for people with immune system problems, somebody on cancer therapy or something like that, to shut the virus down. But the average folks seem to be contagious for 5 or 6 days. The CDC says you can come out of isolation at 5 days now, as long as you continue to be careful for the next 5 days. When you begin to be contagious, when you're exposed to the virus, it takes a day or 2 or sometimes 3 days to have that virus get into your nasal passages or your throat and grow and multiply in a way that then makes you able to shed enough virus to be contagious. So Omicron is different than the others in that it's a little bit faster. And so that's why we're saying 36 to 48 hours is kind of the beginnings of when we expect somebody might be contagious.
Okay, Dr. Whalen, you want to ask your question?
Sure, thanks, James. And I'm just wondering, we have a whole series of mandates for school-age children to be vaccinated in order to attend school. And yet there is a lot of controversy about whether kids should be vaccinated for this or not in order to attend school. And I mean, I know we're getting into public policy questions that are not necessarily medical, but I'm just wondering what your thoughts would be on this.
We've actually had some conversations with the Department of Health physicians about this. And I don't know that we've ever gotten to whether it really should or shouldn't be mandated for this age, but one of the sticking points is it takes them years to get a vaccine added to the list. And so I think there's a practical consideration that not much point in starting down that path because we don't actually know if we'll be needing it. So not a very satisfactory answer, I don't think, but kind of more of a realistic position in that the list of school vaccinations has to be changed by legislation rather than anything more simple than that. That's my understanding anyway.
I just wanted to add something that was kind of ironic. I took my son to Kids City Adventure, which is this indoor playground area in Ward Center. That's pretty new. And, they mandated that everyone have, a certain age, obviously have your vaccine cards to show proof. But, I'm being the smart, I don't know, sorry for the language, but being the smart ass, I'd ask, how do we know about other vaccines? Do these kids have their vaccines for polio, for measles? No answer. But anyway, just wanted to add that little comment about how unfortunate things have been getting lately. And I totally agree that these childhood vaccines are important too. People don't realize that these are maybe even more important than this COVID vaccine, right?
And unfortunately, across the country, maybe I don't know how much in Hawaii, but certainly across the country, there's a major worry that people have just pulled out of healthcare altogether, and out of fear of being exposed or out of this, concern around vaccines and all the rest of that. And we will very likely start seeing much more measles and other diseases that actually are really a problem.
Yeah, and when I did my residency in the Seattle area, we always would get patients from Vashon Island, and that island is notorious for since the 90s of this anti-vax kind of area. And we'd always have to have these red flags, especially when pediatric patients would come in. And I'm sure Dr. Ashton can attest to that. Whenever you have a non-immunized child, that's part of the HPI, right? 2-year-old, fully vaccinated, full term born, et cetera, right? Child. So that's kind of what you want to hear first up. But it's a different world now. So it's it's a scary world. But with that said, let's move on to our next question here. I'm sorry for missing out earlier, but let me see. I think, Lola, I think you're up next. You want to ask a question real quick?
Yeah, I have another question. I'm sure you're much better at this than most of us, Dr. Ashton, but colleagues in healthcare are against the vaccine. We've all seen it. I have no, I don't want to, I love my colleagues, they're great, but how does one have that conversation? Not that I'm here to convince them or anything, but Dr. Ashton, how do you do it? How do you have that conversation?
Well, it's very difficult because they're often not really seeking information. They're really often set with the information they've received from wherever they've received it and aren't necessarily open to information. But the general thinking is you try to understand what the specific concern is and then see if you can provide information around that. I actually am, at HPH, like all other healthcare organizations, we're now mandated by CMS to have people vaccinated or exempt. So we are dealing with those exemption requests, and most, I would say, many of those folks who are applying for exemptions have absolutely no interest in information. It's sad.
Definitely have to deal with a few colleagues myself, Dr. Ashton. I think they've done the right thing now, which is good. But
Yeah.
just real quick, going down the chat, and then we'll get after Kurt, we'll go to Lisa. So Kurt, go ahead.
Sorry for asking so many questions, but I have my daughter tested positive for COVID a week or so ago, but we were just kind of wondering, like, should she get boosted, and if so, when? And
Yeah,
and
good question.
She's vaccinated, so
she's due. Would she be due for a booster? She's at least 5 months after her second dose.
I think so. Yeah.
So assuming she meets the criteria for a booster, the timing for a booster, then you wait until she's no longer in isolation from the infection. So these days, that's 5 days plus wearing the mask for 5 days. So, and we all wear masks anyway. So as soon as she's out of isolation, she could be vaccinated with a booster. And there is good information that says that's probably still a good idea.
Okay. Thank you.
Yep.
Okay, Lisa, go ahead.
Okay, thank you. So I have people in my life who are vaccinated, they're not boosted, but I think that like a lot of people that I know have gotten to the point where they don't really take COVID seriously. They hear in the news that it's really mild, that it's not really, people are not, experiencing these really bad kind of like symptoms anymore. And so, for example, like one of my friends, he ended up infecting his mother, his brother, and his 2-year-old daughter, and then refused to quarantine from them because he was saying like it's not really a big deal anymore. How do you get people to take COVID seriously still when the media keeps saying that it's not as serious? I'm not saying not a big deal, but just not this impending doom that we were dealing with 2 years ago.
I think we'd all like it to be gone. We'd all like it to be nothing to worry about. And I think for many folks, that's their coping mechanism now, is it's nothing. I don't need to think about it anymore. I don't need a booster. I don't need anything. Leave me alone. And I think that's pretty understandable. But I think the scenario that you're describing is the one that we're concerned about, that someone who is not going to get sick themselves may expose others who could get really sick and could end up in our hospitals in the ICU and dying. And that's an unfortunate circumstance because it's preventable for the most part, right? So I think there's been so much information, so much attention, so much daily reporting that people are justifiably fed up. And I don't think that is any longer effective in helping convince them that there are steps to take to help make it better. Sadly.
Another awesome question from Jay. I just want to give a shout out to Jay. At the start of the pandemic, Jay actually brought like a big load of N95s to us out of the community. He was one of the first people to do that over there at Straub. So just want to give a shout out to Jay, give him some props in front of the group here. But Jay, go ahead and ask your question. Thank you.
Hey, thank you so much, James. I just was wondering, you had mentioned earlier that there's going to be a treatment available for treating your nasal passage. And until that does become available, is it recommended to use like a povidone iodine septic treatment in the nasal passages, maybe do a swab after you may have been out at a large indoor gathering, or you may feel like you were exposed, just to help it from, replicating and infecting your lung system?
That's a good question. I actually had intended to say that there's a nasal vaccine in production. So it's not a treatment, it's a vaccine. So it's an alternate to a shot. I have seen people talking about putting various medications and things in their nose. Povidone iodine is useful for bacteria, but not for viral infections. And so I don't know that would be very effective. Once it doesn't take much virus to get into your system. I was just reading a study earlier where they actually literally had volunteers that they infected with COVID in the UK. And they only gave them essentially the same amount of virus as in one aerosol droplet. And they still got sick. So I don't think you would necessarily be successful in, in any intranasal anything. To prevent the attachment of the virus. But I haven't seen a lot of studies about that either, Jay.
Just as a kind of a side note, but as more of a joke, there's a lot of THC research out lately, and the latest article I saw, it wasn't in a validated journal by no means, but it said something along the lines of THC blocking the receptor for viral entry into the cells. And obviously it was not an in vivo study, but I just thought, there's a ton of research out, and I can't wait to see some of these studies too, right? I mean, it'd be interesting to see, right? Like, this, as growing up with Asian grandma, I know here in Hawaii, a lot of grandmas and aunties will just prescribe the mentholatum with the Vicks vapor rub, right? Those two, right?
Right. No, there are a lot of things we've got yet to learn for sure.
Well, any other questions? I'm just kind of scrolling through the screen. I know Dr. Roz Cooper actually had a great question too. It's we're lucky to have you in this kind of this district kind of talk, and there are 53 Rotary clubs across the islands, and not that we expect you to make appearances to 53 Rotary clubs, but Roz is part of a pretty big Rotary club in Metro, I believe, or downtown. Sorry, Roz. But I'll just let you come on the air if you don't mind, and I'll take back my embarrassment not knowing what club you're in. But I want to just ask Dr. Ashton.
Okay, sorry about that. I'm driving, but I just wanted to know. We are a pretty good sized club, and I just wanted to know if you are accepting invitations to speak at other clubs. We are a morning breakfast club, so that might be a little bit challenging for you. But would you be willing to?
Of course. I mean, I think there are a number of us that you see on the TV periodically or whatever that are just trying to do what we can to help get information out and answer questions as people have them. So yes, of course, we're just trying to make sure that whatever we can do to help is done. So happy to know. Oh, you've got somebody else who wants to join your club there, Roz. Happy to know that you'd be interested, and we can connect up.
Very much so, and thank you, because if more of us know and understand the information you're sharing with us today, the better off everybody is going to be.
Yeah, I agree.
And just to give some props to Roz, Roz is a past district governor of the Rotary here in Hawaii, but she's also a part of these national immunization days that Rotary does, where we send Rotarians out to other countries that are still needing immunizations for polio. So Roz has definitely been a big advocate here in Hawaii, and definitely a local champion here in terms of advocating for Rotary and for vaccines in general. So definitely want to give some props up to Roz. Other questions? Anybody else? Lisa, go ahead.
Sorry, one more question. Since vaccines are not distributed equally globally, I mean, theoretically, like even if everybody in Hawaii were vaccinated, boosted, and we all practiced, good policy, does it really matter? Because variations will keep popping up in all of these other areas, and then.
Yeah.
I mean, are we just, is it Groundhog Day every day?
No, it does matter, but you're absolutely correct. And that's one of the reasons why I started with the herd immunity slide. Herd immunity would require that everybody around the world were all vaccinated with the right vaccine at the right time, kind of all together, and then we might have a shot at it. But without that, there are going to be variants that will continue to develop and to, cause trouble. The hope is that the more the population has immunity, either through vaccine or through infection or both, the hope is that that will help to continue to decrease the number of people who can be infected and decrease the pressure as far as variants. But there's such inequity around the world that that's going to be a while.
Great answer. Speaking of Groundhog's Day, I don't know if you guys heard, but I think the groundhog died, sadly. So hopefully that's not a bad omen for this year. And hopefully it wasn't COVID that killed the groundhog either, right? But with that said, Rod, I saw your hand up. Go ahead with your question, please. Can you unmute, please?
You talking about me, my head?
Okay. Sorry. Thank you for the presentation. I just wanted to be sure about mask wearing. There are a lot of different kinds of masks being sold out there, and you hear constantly N94s and N95s are the ones to wear, but does it matter as long as you're wearing some kind of mask?
Yeah, the CDC says it matters. I'm not so sure that it matters as much as they are telling us. To me, the most important thing is to wear a mask properly, to wear a mask that's got several layers. And so what I do is, or what I was doing until recently, is I get a surgical mask, the kind that you buy at Costco or Safeway or wherever you like to shop, and then a cloth mask over it. And so the surgical mask sometimes will gape on the sides, depending on how it fits you. And the cloth mask, if it's fitting well, will help with that and keep it more closely applied to your face. That was found to be almost as protective as N95s back in some earlier studies prior to Delta. I don't think that the physical characteristics of the virus have changed all that much, so the masks should still work that way. What we see is a lot of people wearing, the either N95s or versions of N95s or the KF94s. And if they gape, they're not going to protect you with that 95% filtration that they're advertising, right? So in healthcare, when we wear N95s, you actually have to do something called a fit test, where you actually make sure that you're not breathing around the edges of that mask, that you're breathing through it. And then you get that 95% filtration. Without that, it's a guess. And so I think that we can make a lot of fuss about the way the mask is made, but it's much more important how the mask fits.
Great, thank you very much.
Thank you for reminding me, Dr. Ashton. I have to do my fit test next month, so appreciate the reminder.
Yeah, you're welcome.
Yeah, and just as a kind of a side note, I remember when I was a medical student, in the OR, they'd always have us put on these masks, and one of the things they always taught us was, if you cough, don't turn your head and cough, because you'll go through that gape on that side and spew your cough out. So just a reminder, when you cough, it sounds kind of gross, but you're coughing right into your mask to protect others. You might have to change your mask out if it's wet, but otherwise that's kind of the idea. But Lolos, was your chat? I'll just let you ask. Okay, you were just joking about. Okay, he's asking. He said something about like, "Whoa, what about your CO2 levels?" But I think he was kind of a joke, right?
No, well, people have objected to mask wearing on that basis. There's no data to show that that's a problem.
And I guess any other questions? Kind of going through. Wow, it's 5:59. We might actually finish on time here. Well, shows to the power of the speaker too, right? You did a very good job with your presentation and answering all the questions, and it looks like everyone's satisfied. So hope everyone feels empowered. I hope everyone feels like they could actually help, and maybe even help answer some questions in their circles, and kind of help dispel some of these myths and help us get through this together. Just wanted to kind of ask Dr. Ashton for any final remarks and kind of go from there. Thank you.
Yeah, I just want to say thank you for the opportunity. It's always good to be able to, find out what people are thinking about and answer the questions. Of course, it's just the information that I have, and I'm sure you can read something else different tomorrow. There's so much information out there, but hopefully that was helpful, and I appreciate the opportunity.
And thank you again, everybody. Another round of applause for Dr. Ashton, please.
Bye.
And just to end, we got to show off our venue. So I do want to invite you to our Rotary Club, the Honolulu Sunset. Just going to turn my laptop here a little bit to kind of show the screen off here. It's our little view of the harbor here, and we enjoy our sunset kind of every night. So just wanted to invite you out here, and we do have some HPH Rotarians here. Cecily Wing is right next to me here, and our COO Kapiolani Gidget is also one of our members too. So, but yeah, we have to host you one of these days for dinner. And again, I know Roz and there definitely be other clubs interested in contacting you, but I'll definitely, if you don't mind, I'll share contact with the ask. And
sure,
we'll
that's fine. Great. Thanks a lot.
Take care.
Bye-bye.
Yep. And lastly, to the other Rotarians in the room, if we'll, as Naomi perfectly reminded in the chat window, where we'll have our next session on March 3rd, discussing mental health aspects just in general, but also maybe pertaining to COVID as well. And we have some good speakers lined up for that. Just kind of reach out. I'll definitely send out reminders, and I know Naomi and Sandy will actually send out into the district at large. So thank you again, everybody. Have a great rest of your night. Thank you.
Good job, James. Good session.
Thank you, Sandy. Thank you so much for helping us out and getting this organized for us.
Thanks, James, for putting this on for us.
Bye, everybody.